Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. So this is the 163rd episode of the Codecast, and I know a lot of you have been waiting for the final rule that has come out for Medicare, the fee schedule, what we're in for, and it was published on December 1st. It actually was published in the afternoon, so I actually did a Talk 10 Tuesday regarding that PPE code that nobody's paying for early in the morning, and somebody had asked me, well, when is the fee schedule and the final rule coming out? And we found out that it came out in the afternoon. So I've been combing through it. I'm going to give you some highlights today. I know that I do have a webinar coming up on December 17th that goes over all the changes, but I wanted just to give you some quick highlights so that you can take that and get an updated webinar when you can, hopefully before the end of the year. But I wanted you to have some insight in what to expect because it is going to be absolutely crazy. And just some of the things as I'm reading through this, I think it's a little bit hard to understand, so let me kind of give you some insights. So first of all, let's talk about our fee schedule. So the rate setting, which is the conversion factor or the multiplier, is what's going to change, and it's going to change big. So CMS finalized a series of standard technical proposals involving practice expense, including implementation of the third year of market-based supply and equipment pricing update, and did a lot of refinement to update premiums and data involved in malpractice expense, geographic practice expense, and all of that. Also, there is something called the budget neutrality adjustment, and that is a legal position. It's required by law to account for changes in RVUs, which we haven't gotten that file yet, actually out yet, but including significant increases for the E&M service codes or the E&M visit codes. But even though we're getting increases in the value of those codes, the RVU of those codes, the final calendar year 2021 physician fee schedule conversion factor, which is our multiplier, is going from 3609, which is what it currently is in 2020, and it's going down a total of $3.68, which is huge, about 10.5%, down to 3241. And this is a statutory update. So I know that a lot of practices and a lot of different associations are out there saying, you know, you need to do everything you can, Congress, to stop this. And just so you know, there is currently a bill working its way through Congress, and it's called the Holding Providers Harmless from Medicare Cuts During COVID-19 Act 2020. And this would freeze Medicare payments at its current rate for 2 years. But as far as Medicare is concerned, this is not one of their priorities right now. So their priorities is really pushing things out. I should say Congress. It's not their priority right now. And especially after listening to the speaker's conversation yesterday, it has nothing to do with Medicare. It's all about dealing with the vaccine that, thank you very much for the current administration for getting that going, but also about transitioning to the new administration. So I don't see this changing. If it changes, there may be a modification sometime in 2021, but it's not even on their agenda. So be aware that we are getting that fee schedule update as of January 1st, and your physicians need to be aware of that. Hopefully the RVU file is going to be coming out soon. So you will see, since we're getting the decrease in the multiplier and we're getting an increase in the RVUs, you're probably looking at, for E&M services anyway, maybe about a 9% reduction instead of 10.5%. But the ER doctors and surgeons are going to get hit very hard with this, especially orthopedic and general surgery. So really make sure that you take a look at that. Another thing that has been kind of controversial, and I mentioned last week just about what everybody's looking for as far as OIG and CMS as far as auditing telehealth services involving Medicare and other communications technology services. Medicare loves saying that we're, finalizing the addition of the following services to the list. And, they've added so many services, things that have to do with group psychotherapy and, domiciliary, rest home, custodial care services, many established patient services, not office visits specifically, but home health care, cognitive assessments, care planning services, but they've also added some new codes for visit complexity, inherent to certain outpatient services, and prolonged service codes. And so you really want to take a look at those. But the biggest thing to keep in mind is that they are HCPCS codes. They are G codes. You're going to want to look for G2211 and G2212, respectively. And just know whenever you see a G code, it's a tracking code for Medicare, and it means, G, we're watching you. So you may or may not want to consider those under telehealth because it would be really hard to support. So just take a look at those. Make sure you're really researching out what those are going to be, because that can be really interesting. Also, Medicare said they are finalizing the creation of a third temporary category of criteria for adding certain services to the telehealth list. One of the categories, or I should say the telehealth to category 3, they're saying this is just something that will be temporarily a category when it's needed, when we have something like a public health emergency, and phone calls are on that category. So are ER visits and therapy services, because they're going to roll those back. So just be aware that those are being considered for the category 3, if you will, basis on some of these services. So just don't always think that just because you see something in the news or you see a headline or you've clicked on some article, if you haven't read it all the way through, you really need to understand that we're going to have some changes when the public health emergency ends, and they were pretty clear on that within the final rule. Remote physiological monitoring services. So this has been really a big deal, and they clarified some things in the final rule, and a lot of things throughout the final rule says as we finalize, which makes me wonder if they still have wiggle room to make it happen. To me, it seems like they do, because they say in addition, we have finalized, or we are finalizing. But here is one of the permanent finalizations. So permanent policy, 2 modifications to remote physiological monitoring services, or RPM services. And this was in response to PHE and to the COVID pandemic. So it says, we clarified after the PHE ends, there must be an established patient-physician relationship for RPM services to be furnished. So right now, they're allowing that for a new patient if a telehealth visit was done prior to that. But after the public health emergency ends, they're saying that that is no longer going to be the case. They also changed some things that is allowing for auxiliary personnel looking at some of the prolonged care, but it has to be in relationship to what a physician does as well. Then another thing that was brought up as well was they clarified for NPPs, which are your advanced practice providers, so NPs and PAs, a position who are eligible to furnish E&M services may also furnish the RPM services. So they really like to utilize that policy that if you are somebody that can bill directly for E&M services to Medicare, then you should qualify just like a physician to be able to bill for certain other services, which makes sense. And so that's where you want to really be aware of that. So, LVNs, medical assistants, RNs, et cetera, LPNs, they're not going to be qualified professionals to be able to do that. Immunization services. So they're maintaining the payment rates for immunization administration services. And so that's not going to change in 2021. So they're considering that stability for public health concerns, as far as a lot of people, really after the pandemic decided not to go get their immunizations, and they're really trying to make that happen. Now, one of the rules, and I'm just going to touch on it because I think I'm going to ask to do not only a Talk 10 on this, but with ICD-10 Monitor, but there's some kind of interesting rules when it comes to direct supervision by interactive telecommunication. So for the duration of the PHE and for purposes of limiting exposure to COVID, Medicare did adopt an interim policy revising the definition of direct supervision to include a virtual presence of the supervising physician or practitioner using interactive audio-video, which it's hard to understand how that actually works. They also recognize that in some cases, the physical proximity of the physician or practitioner present additional infection exposure or risk to the patient and or practitioner. And that's why they said that they're going to allow direct supervision to be provided using real-time interactive audio and video. It excludes phone calls that don't also have video. And they said through the latter end of the year in which PHE ends. So it's going to be, since it's now scheduled to be there until January 23rd, they're going to allow it till the end of next year. But here's something interesting. They said we sought information from commenters as to whether there should be any guardrails in effect if we finalize this policy. I was one of the commenters. I'm like, you better believe it, because I still think there's a lot of risk this policy introduces, especially to beneficiaries as they receive care from practitioners that would supervise virtual care this way. And I'm concerned about the safety or clinical appropriateness of this, and also the potential concerns around induced utilization and fraud because it's paid at 100%. So they're finalizing, and that direct supervision may be provided using real-time interactive audio and video technology through the end of the calendar year for which PHE ends. So they're not going to put it, finalize that. You're able to do that once the public health emergency ends. But more on that later. I just think that's going to be really interesting. And then payment for E&M services, when we talk about some for end-stage renal disease, they were talking about setting some of these visits that changes could be laid out, and transitional care management, just as far as documentation policies and how is that going to happen. So they're going to finalize revisions to the times used for rate setting. And so they just said that they're going to rely on some of the increases in the values based on what they're increasing the RVUs under the E&M services as well. So a lot of different things have changed as far as what they're going to allow based on the public health emergency, and then some things are still going to be temporary. Now, regarding some scope of practice issues, this is something that I thought was interesting. So it said for supervision of diagnostic tests by certain non-physician practitioners. So they finalized their proposal in making permanent following the COVID-19 that a policy for the duration of the PHE to allow nurse practitioners, clinical nurse specialists, physician assistants, and clinical nurse midwives, those are the NPPs, to supervise certain diagnostic tests within their scope of practice in state law. And they're adding certified registered nurse anesthetists to that list, which I think is a great idea. And so as long as these practitioners maintain the required relationship, and there's a statutory relationship under Medicare with supervising and or collaborating physicians. So you still have to have basically a supervising physician to be able to be part of that supervision of that diagnostic test. But I thought adding the CRNA, so the certified registered nurse anesthetist, was a great idea. I can't believe they weren't on it before. Pharmacists. Now let's be clear on what pharmacists providing incident to physician services. And this came out quite a bit, mainly because of pharmacists have been doing some of the counseling for the COVID testing. And I've noticed that they're trying to bill the 99211, which is inappropriate. Remember, under a pharmacist state scope of practice and applicable state law, they don't have E&M coverage. And so it's not a Part D benefit. So CMS is clarifying that pharmacists may fall within the regulatory definition of auxiliary personnel under their incident to regulations. They may provide service incident to the services and under the appropriate level of supervision. If payment for those services is not made under the Part D, what they're talking about is under care management. So be aware that it's not about billing, an E&M service. It's about the care management services that they can provide. Some of those services, as far as checking on medications, et cetera, where they couldn't before, especially under CCM, for the providers. So just know that they're kind of expanding their role with what the pharmacists can do. Medical record documentation, obviously they're talking about the patients over paperwork, the broad modifications in the fee schedule, and who can review and verify documentation now that we're getting into the 2021 rules. And I wanted to just put a side note. Thank you for everyone who's been ordering, and I think we've sold over 100 units of my E&M changes. And so I think that's really a good thing. And we've gotten a lot of positive feedback because I'm also including a Q&A with it. So it's a 2-page Q&A so that you can see, oh, well, I have this question. What if this happens? And I'm pinpointing in the E&M, in the CPT book where you find that answer. So one of the things on the broad modifications on documentation requirements for physicians and certain NPPs. The final rule, they clarified, so Medicare clarified that physicians and NPPs, including therapists, can review and verify documentation entered to the medical record by the medical team for their own services that are paid under the physician fee schedule. They are clarifying that therapy students and students of other disciplines working under the physician or practitioner who furnishes and bills directly for their professional services to the Medicare program may document in the record, but you have to show proof that you've reviewed and verified, so signed and dated, and they said signed and dated by the billing physician, practitioner, or therapist. Now, here's the one thing about the time. If you're leveling your code in 2021 based on time, you can't use that time that practitioner, that ancillary staff spent to include in your timed visit because it can only be by the actual provider. But you can use their documentation as part of your medical decision making and your whatever they're doing as far as your exam that has to be done and your problem pertinent history. So just know the documentation that your ancillary staff performs can be included as the documentation portion for medical necessity. It just cannot be included as part of the time if you're leveling your code based on time. Okay, so let's take a look at our coding question today. And our coding question is GI. It's a colonoscopy. It says, Terry, we did a colonoscopy by snare, 45385, and then about 2 hours later, after the patient was sent to the holding area, we noticed bleeding. So took the patient back to the endoscopy lab for a colonoscopy with control of bleeding, 45382. We added a 59 modifier since it was on the same date, and we were denied the second procedure. Do you have any advice? Okay, so this is where I think sometimes you're missing some of the updates and you really need to make sure that you are heads up for those. And I also had a podcast, I think sometime last year when I did a modifier highlight. So really go back and find that. You can always find every single episode on my website at terryfletcher.net. But the 59 modifier has something called subset modifiers. So they have the XP, the XE, the XS, and the the XU. And so the 59 is used to reflect a distinct procedural service at the same encounter. So there could be an edit, and usually it has a 1 indicator with Medicare. And so to bypass that edit for a special reason or a special, service today, then you would put a 59. But when the patient leaves the procedure room, and this is the case for the endoscopy lab as you're describing, and they're going to the holding area or to the medical floor or to the surgical floor, and then has to return to the procedure room, then your modifier should reflect that. And the subset modifier, that means it's kind of a stepbrother of the 59, is XE. That's a separate encounter. And so that means a separate encounter for services performed by the same physician. So this will not only get you paid for each procedure, but the payment will be reflective of 100% of allowable. Now remember, that's not 100% of what you bill. It's what's allowed by the payer, and not 50% for the multiple procedure reduction that you sometimes get at the same encounter. The reason is that you are at different encounters, different times, different setting, where one was in the lab, they went back to the floor, thought they were fine, were checked on in a couple hours, and then had to be taken back to the procedure room. And that's just like they never were there before. So in this case, that would be the XE modifier. So make sure you familiarize yourself with those X modifiers. It can make a big difference. Today's coding question is brought to you by OAND, the Ontario Association of Naturopathic Doctors, findand.ca, Toronto, Canada, championing the success of neuropathic physicians and the health of Ontarians. Learn how laughter can help your heart at newswise.com. So I like that new sponsor. We appreciate them. So this week I wanted to end with my personal tidbit. I'm going to tell you about the Steelers. That's who I am. We're 11-0. Ugly game this past week. But what do you expect? We were supposed to play on Thanksgiving night, and then they moved us to Sunday, and then they moved us to, they said Tuesday. Then they said, how about Wednesday? Let's just do a 12:40 in the afternoon. I'm like, you've got to be kidding me. And again, now, because that one game was moved, now another game's moved. So now our next game is Monday at 2 p.m. By the time you hear this, it'll already been played. And that's 2 p.m. my time. It's 5 p.m. Eastern time. And nobody can watch it west of Ohio. They only have this small market right now because of some kind of licensing issues with Fox Sports. So I have NFL tickets, so I'll get to see it. And thank God I'm working remotely right now. But geez, first a Wednesday game, and then after being rescheduled 3 times, and now another matinee. But we're winning every week, so what can you do? And if you love football like I do, and not just Steelers, but don't forget to listen to my weekly WTF What the Football podcast on Steel City Underground podcast. I hope you're getting the rest of your holiday shopping done. I am done, just about done. I have to still do some last minute things for my stocking stuffers. And if you're trying to find that last minute thing for a stocking stuffer, or let's say you have a daughter who has a brand new boyfriend, you don't know what to get them some lottery scratcher tickets. Every 7-Eleven, every liquor store, they have them. Every gas station has them. And they're usually anywhere from $1, $2, $3 each. Some are $5. I actually saw that some are 10. That's ridiculous. But they're great things to throw in the stockings. Even throw them into your kids. But the biggest thing that people love me for is I do this and I tape a penny to at least one of them if they get multiple ones so that they can use it to scratch off. That's just a little bit of a hack for you. So hopefully everyone, you're getting that done in your holiday shopping. So take care, everyone. Make it a great rest of your day, a great week. And I'll talk to you next week on the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.